It seems like lately, you just cannot drive down a highway or even scroll through your phone without seeing an ad for a medical spa.
Oh, yeah. They are literally everywhere right now.
Right. And they offer just everything under the sun. You see the Botox, the dermal fillers, and increasingly you're seeing ads for things like vaginal rejuvenation or vaginal tightening.
Yeah, right alongside the laser hair removal and facials.
Exactly.
Yeah.
It's presented as just another quick, routine cosmetic touch-up to, make you feel more youthful.
The messaging is incredibly persistent. It frames the entire process as this straightforward, consumer-friendly wellness service. Like, you just walk in on your lunch break, get a procedure, and walk out feeling refreshed.
But that stark contrast between this breezy marketing and the actual medical reality,
Right.
it really got us thinking about a very specific, highly vulnerable group of people.
Because it's not always just a cosmetic client walking through the door.
Right. What happens when the person walking into that clinic isn't just looking for a cosmetic boost, but is actually a cancer survivor?
Someone who is dealing with, severe painful side effects from their oncology treatments.
Exactly. We really wanted to know how the medical vetting process for vaginal tightening, specifically using things like lasers and radiofrequency devices, how that drastically changes if the patient has a history of cancer.
And that underlying medical history completely flips the script on how we view these procedures.
It really does. So to explore this, we are pulling from a really diverse stack of sources for our deep dive today.
We are looking at clinical consensus statements from the American Urogynecologic Society, official safety communications from the FDA, and specific clinical trial protocols like the Revitalize study.
We also have patient rehabilitation guides from the EVQ Cancer Network. And what stands out immediately across all of these sources is the terminology itself.
Yes, the terminology is key here, because the billboard says vaginal tightening, but for a cancer survivor, the actual medical condition they are desperately trying to treat is called the genitourinary syndrome of menopause, or GSM.
I noticed that term came up constantly in the readings. And, it sounds vastly different from just feeling a little less firm.
Oh, it is entirely different. GSM is a severe, painful loss of tissue elasticity, moisture, and just overall function.
Wow.
Yeah, it can make everyday activities, let alone physical intimacy, just excruciating. So the stakes are incredibly high.
Okay, let's unpack this, because before we delve into how a cancer diagnosis alters the rules, we really need to establish what these machines actually do to human tissue.
Right, we need to understand the baseline.
Because I was reading through the mechanics, and honestly, it feels a bit counterintuitive. Like, how does firing a laser into delicate tissue supposedly fix a problem like dryness or loss of elasticity?
Well, it relies on a very specific biological trigger. The core technology behind non-surgical vaginal tightening involves energy-based devices, which you'll often see abbreviated as EBDs.
Okay, EVDs.
Yeah. And these machines primarily use fractional CO2 lasers, ERYAG lasers, or radiofrequency energy.
And what do those actually do?
To break that down slightly, a CO2 laser vaporizes tiny collars of tissue. An AirYAG laser specifically targets the water molecules within the cells, which theoretically causes a bit less residual heat damage.
But the end result is the same.
Exactly. Regardless of the specific laser, the overarching goal is the same, creating controlled thermal damage inside the vaginal canal.
Wait, so you are intentionally hurting the mucosal lining?
Yes, you are creating thousands of microscopic injuries. They call them microablations.
Ouch. That sounds intense.
It is. The theory is that by causing this targeted thermal damage, you basically force the body into a state of panic. The body's natural wound healing cascade kicks in, rushing to repair these micro-injuries.
And that healing is what causes the tightening.
Right. In doing so, it stimulates neocollagenesis, which is just the production of new collagen and elastin fibers, and it increases blood flow to the area.
So for someone experiencing just a mild natural thinning of the tissue from aging, this fresh tissue formation can theoretically restore some moisture and flexibility.
Theoretically, yes.
But this is where we really need to introduce a heavy dose of reality from the sources. Because, well, the marketing hype gets very aggressive here.
It really does.
According to the Cleveland Clinic and the American College of Obstetricians and Gynecologists, the term vaginal rejuvenation is not a recognized medical term at all.
No, it is purely a marketing invention.
The sources point out that when a patient walks into a clinic complaining that they feel, loose, it is very often a pelvic floor muscle issue.
And that distinction between muscle and surface tissue is absolutely paramount during any baseline screening.
Because the laser can't reach the muscle, right?
Exactly. A laser only penetrates the superficial mucosal layer. It has absolutely no mechanism to tighten the underlying pelvic floor muscles.
I kept thinking of it like trying to fix a sagging mattress by ironing the bed sheets.
Oh, that is a fantastic analogy.
Right. Like you can use a laser to make the surface fabric look incredibly smooth and rejuvenated, but if the structural springs underneath are weak, the bed is still going to sag.
Exactly. And if you read the screening guidelines from the Women's Health Clinic source, they demand that a proper baseline clinical workup differentiates between muscle support symptoms and tissue symptoms.
Like separating a prolapse or urinary leakage from surface dryness and friction.
Right. If your muscles are weak, you need pelvic floor physiotherapy, not an expensive laser.
And the level of clinical rigor expected before a laser is ever even turned on is substantial.
What's fascinating here is that, according to the American Urogynecologic Society consensus statement, a routine screening requires a highly focused gynecological exam.
Let's clarify what that entails for you, the listener, because it really underscores how medical this whole process is supposed to be.
Sure, it includes a visual inspection, a speculum exam, and a bimanual exam. During a bimanual exam, the doctor places 2 fingers inside the vagina and their other hand on the patient's lower abdomen.
So they are physically checking everything.
Yes, they are physically pressing and feeling the size, shape, and mobility of the uterus and ovaries to check for any abnormalities or pain. They also check cervical cytology, which is essentially a pap smear.
And they explicitly rule out any active infections.
You absolutely cannot bypass these steps. And keep in mind, that is just the baseline for an otherwise healthy patient.
Right, which brings us to the core of our deep dive.
Yeah.
When we introduce a history of cancer into the equation, the intake process evolves from a routine screening to this high-stakes medical investigation.
It changes everything.
And that brings us to the largest demographic of cancer survivors actively seeking out these treatments, which is breast cancer survivors.
Yeah, a huge portion of the patient base.
But I found a really fascinating contradiction in our sources regarding this specific group. The British Society of Sexual Medicine states that using localized topical vaginal estrogen carries negligible risks.
They do, yes.
They actually recommend it as a safe option for breast cancer survivors after a shared decision-making process with their doctor. So, if a cheap, widely available estrogen cream works, why are so many of these survivors turning to highly expensive experimental lasers?
Well, it highlights a massive gap between clinical theory and the lived reality of these patients. While the BSSM provides that reassurance on paper, the situation on the ground is just far more complex.
Because of the type of cancer.
Exactly. A large percentage of breast cancers are estrogen receptor positive. That means the cancer cells literally utilize estrogen as fuel to multiply and grow.
Oh, wow. So giving them estrogen feels dangerous.
Right. Consequently, many oncologists are deeply reluctant to prescribe even a localized topical estrogen cream.
Even if the absorption in the bloodstream is super minimal, the doctors simply don't want to risk it.
They often flat out refuse to take that chance. And furthermore, even when an oncologist is willing to write the prescription, the patients themselves are often terrified to use it.
I mean, that fear is completely understandable. They've just survived a grueling battle against a disease that feeds on hormones.
The psychological hurdle of introducing any form of estrogen back into their bodies is simply too high for a lot of people.
But the tissue dryness isn't just a natural symptom of aging for them, right? It is actively being driven by their cancer medications.
Yes. A standard part of post-cancer therapy involves drugs called aromatase inhibitors.
And what does do?
These medications do more than just block estrogen receptors. They systematically shut down the body's ability to produce estrogen almost entirely.
Wow. So it creates an environment of profound estrogen deprivation.
Exactly. And the resulting genitourinary syndrome of menopause is not gradual. It is a rapid, severe onset of extreme dryness, tissue atrophy, and dyspareunia, which is severe pain during sexual intercourse.
And because traditional hormonal therapies are largely off the table, breast cancer survivors find themselves cornered.
They really do. They become the primary candidates seeking relief through these energy-based devices.
I want to look at how these specific survivors are evaluated before they can undergo a laser treatment. Because I was reading through the documentation for the Revitalize trial.
Ah, yes, the Revitalize trial.
Right, which is testing fractional CO2 lasers specifically for breast cancer survivors suffering from these exact symptoms. And the clinical criteria just to get in the door seemed incredibly strict.
Oh, they are. The clinical vetting leaves zero room for ambiguity. The researchers are looking at very, very precise timelines regarding the patient's oncology treatments.
Like, how do clinicians determine if someone on these harsh medications is a safe candidate for thermal tissue damage?
Well, to even be considered for the revitalized trial, a patient must be at least 12 months out from their primary therapies, meaning surgery, chemotherapy, or radiation must be fully completed for a full year.
Wait, 12 months? Why mandate that long of a waiting period?
Furthermore, if they are taking those aromatase inhibitors we just discussed, they must have been actively taking that specific medication for a minimum of 6 months before registering.
But if a patient is suffering from severe pain and dryness, why force them to wait 6 months to a year before offering the laser?
Because it is about establishing a stable biological baseline. The clinicians have to ensure that the medication has done all the damage it is going to do.
Oh, I see.
Yeah, if they treat someone who is still actively undergoing primary chemotherapy or who just started hormone suppressants, the tissue is in a state of rapid flux.
It's changing too fast.
Right. Trying to measure the effectiveness of a laser on tissue that is actively degrading is like trying to hit a moving target.
That makes total sense. So they require those strict timelines to ensure the atrophy is completely established and stable.
Only then can they safely introduce thermal microinjuries and accurately observe if the tissue actually manages to heal.
So the screening shifts from a basic anatomical check to this rigid audit of their oncological timeline.
Exactly.
And breast cancer survivors, under very tightly controlled circumstances, might actually find non-hormonal relief through these mechanisms. But I want to pivot to a different type of survivor entirely.
Let's do it.
We have been discussing the effects of systemic drugs, like the hormone blockers. But what happens when the cancer treatment is localized directly in the pelvis? Does someone who survived cervical or endometrial cancer go through that same laser screening?
No. The medical narrative fractures completely at this point. For survivors of gynecological cancers, the life-saving treatment frequently involves pelvic radiation.
And that changes things.
Oh, the introduction of radiation fundamentally rewrites the rules of cellular biology in that area.
The sources detail a procedure called intracavitary brachytherapy. From what I understand, the radioactive source is placed directly inside the vaginal canal, right next to the tumor in the cervix or uterus.
Yes, that is correct.
I'm just trying to visualize what that kind of concentrated localized radiation actually does to the surrounding healthy tissue compared to the systemic drugs we just talked about.
The physical changes are profound. Systemic hormone deprivation from breast cancer drugs dries the tissue out severely, stripping it of moisture. But pelvic radiation, however, causes structural devastation.
What do you mean by structural devastation?
It literally damages the microblood vessels, drastically reducing blood supply to the area. And without adequate blood flow, the tissue loses its elasticity and is replaced by dense, rigid, fibrotic scar tissue.
So it's not just dry, it's actually changing form.
Right. Think of it like taking a supple, flexible piece of silk and exposing it to extreme heat until it becomes stiff, brittle parchment.
Wow. And if breast cancer treatments dry out the tissue, pelvic radiation practically turns it into, fragile parchment.
Yeah.
The statistics from the EviQ Patient Rehabilitation Guide in the Frontiers Journal really underscore that severity.
The numbers are staggering.
They report that pelvic radiation causes vaginal stenosis, which is the physical narrowing and shortening of the canal, in up to 88% of patients.
Yes, up to 88%.
If the tissue is that compromised, how do clinicians evaluate these patients for laser treatments?
Well, they don't.
They don't evaluate them at all.
If we connect this to the bigger picture, the clinical consensus statement from the American Urogynecologic Society is definitive on this issue. Prior pelvic radiation is an absolute contraindication for vaginal energy-based devices.
Absolute contraindication, meaning do not do it.
Exactly. There is zero clinical evidence to support firing a laser into radiation-induced vaginitis.
I mean, if the mechanism of a laser requires the body to mount a vigorous healing cascade, and radiation has completely destroyed the blood supply needed for that healing, firing a laser into that environment seems incredibly dangerous.
It is highly dangerous. It is attempting to trigger a biological response that the tissue is simply no longer capable of producing.
So you aren't regenerating anything.
No. Instead of generating fresh collagen, you are simply inflicting severe, unhealable thermal burns on fragile, irradiated tissue. You do not pass the screening. You do not get the laser.
Okay, so if they are strictly barred from utilizing these high-tech cosmetic devices, what are they evaluated for instead? Like, how do they find relief?
The medical workup completely bypasses energy devices and shifts entirely to active physical rehabilitation.
Like physical therapy?
Yes. Starting approximately 6 weeks post-treatment, once the acute inflammation from the radiation has settled, the clinical focus becomes prescribing and managing the use of vaginal dilators.
Ah, the EVQ guide dedicates a lot of space to this.
Mhm.
Dilators are these smooth, graduated, tube-like medical devices, right?
That's right. The doctor determines the appropriate starting size, and the patient is instructed to use them 3 to 5 times a week.
And it requires the patient to actively stretch the irradiated tissue. But how does physical stretching succeed where a high-tech laser fails?
Well, it tackles the structural fibrosis directly. As the radiation damage heals, it forms crosslinks of rigid scar tissue.
Wow.
The mechanical pressure from the dilators physically breaks down those crosslinks.
So it stops it from shrinking.
Exactly. It prevents the walls of the vaginal canal from literally fusing together. It is an arduous process, but it is necessary to maintain the length and flexibility of the tissue.
And while this obviously plays a vital role in preserving a patient's ability to engage in sexual intimacy, the medical vetting prioritizes an even more pressing concern here.
Yes, the oncological follow-up exams.
Right.
Precisely. If the canal becomes completely stenotic-like, if it narrows and shortens into a rigid tube of scar tissue, the oncologist is physically blocked from performing future pelvic exams.
Oh, wow. They literally can't get in to check.
Right. They cannot insert the necessary instruments to inspect the cervix or the vaginal vault to ensure the cancer hasn't returned. So the prescription of dilators is quite literally a matter of life-saving surveillance.
That is just incredible. We are looking at a massive divergence based entirely on a patient's medical history.
A total fork in the road.
Right. A breast cancer survivor might cautiously qualify for a laser trial, while a radiation survivor requires mechanical dilation just to allow their doctor to check for recurring tumors.
Exactly.
Which brings us to the ultimate danger zone of this entire topic. We started by talking about med spas and slick marketing.
Yes, the billboard ads.
Right. So what happens when the person holding the laser device at a local strip mall clinic doesn't understand these complex biological differences? What actually happens to the tissue when they fail to properly screen a cancer survivor?
The consequences are, frankly, catastrophic. The Statin EWS investigation and the official safety communication from the FDA paint a very grim picture here.
The FDA had to step in.
Yes. The FDA became so alarmed by the rising number of adverse outcomes that they issued public warnings against using these devices for the vaguely defined purpose of vaginal rejuvenation.
Because they were seeing the direct fallout of these failed medical screenings.
Exactly. They monitor a system called the Manufacturer and User Facility Device Experience Database, or MIU.
MID, right.
And through MIU, the FDA cataloged numerous reports of severe adverse events following these commercial laser treatments. Patients were reporting chronic, debilitating bladder pain, severe internal scarring, and irreversible thermal burns.
And the data intersects really aggressively with our topic today, because the sources cite a staggering statistic. 70% of cancer survivors experience sexual health problems.
It is a massive number.
That is a massive demographic of people who are suffering in silence, who feel ignored by traditional medicine, and who are highly vulnerable to predatory marketing, promising a quick, painless, high-tech fix.
And because they are desperate for relief, many of these survivors end up in consumer clinics where the intake process is just woefully inadequate.
They aren't checking their history.
Right. They are treated as standard cosmetic clients. They receive high-intensity energy treatments on tissue already decimated by severe estrogen deprivation or undisclosed radiation therapy.
And we know how that ends.
Because their compromised tissue cannot mount the necessary healing cascade, the microablations never heal. They simply turn into permanent scars, leaving the patient with chronic pain far worse than their original symptoms.
So what does this all mean for you, the listener? Whether you are navigating these issues yourself, supporting a partner, or just trying to be a more informed consumer, understanding what a legitimate medical evaluation looks like is your best defense.
It really is.
The Women's Health Clinic guidelines provide a crucial framework for spotting red flags during an intake. If you walk into a clinic seeking treatment for tissue dryness or pain, and the provider does not explicitly ask for a detailed history of cancer treatments, that is a massive red flag.
Absolutely.
If they do not inquire about unexplainable pelvic pain or investigate episodes of postmenopausal bleeding before ever suggesting a laser, you should walk right out the door.
Demanding clinical rigor is simply non-negotiable. A baseline workup is not a formality to see if your credit card clears, It is a vital medical gatekeeper.
Right.
Health organizations like the National Institute for Health and Care Excellence, or NICE and AUGS, they continuously emphasize the severe lack of long-term safety data regarding these devices.
So for the oncology population, energy-based devices are still largely experimental.
Yes. Thorough diagnostic vetting is the only barrier standing between a vulnerable patient and irreversible harm to their pelvic health. Asking hard questions about why a machine is being recommended and what biological mechanism it uses is essential.
Well, to bring all of these complex threads together for you, while vaginal tightening is plastered on billboards as an effortless spa treatment for aging or changes after childbirth, the reality for cancer survivors is a very delicate medical balancing act.
Very delicate.
If you are a breast cancer survivor suffering from the severe side effects of aromatase inhibitors, you might find relief, but only through meticulously vetted, carefully controlled clinical protocols.
Correct.
Conversely, if you survived a gynecological cancer via pelvic radiation, those same lasers are biologically incompatible with your tissue and could cause severe burns. Your path relies on physical rehabilitation like dilators.
The underlying medical history must dictate the biology of the treatment, completely irrespective of whatever the marketing brochures say.
Knowing the intense medical reality behind these cosmetic buzzwords empowers you. It empowers you to recognize when a clinic is skipping vital safety steps, to ask about the mechanisms of the tools being used on your body, and to demand a thorough clinical evaluation before agreeing to any procedure.
And, it leaves us with a fascinating and somewhat provocative thought regarding the future trajectory of this entire industry.
Oh, what's that?
Well, as oncology improves and cancer survival rates continue to climb, we have an ever-growing population of people living decades beyond their initial treatments.
Thankfully, yes.
Right. But as the massive cosmetic wellness industry increasingly targets this demographic, we have to wonder, will regulatory bodies eventually be forced to intervene on a much larger scale?
Like mandating rules for the clinics.
Exactly. Will we reach a point where health authorities mandate specialized, legally required oncological screenings before anyone, regardless of their perceived health status, is permitted to book a commercial rejuvenation session?
Wow. It is a profound question to consider. Right now, the gap between a billboard promising a quick fix and the complex reality of a survivor's cellular biology is just vast.
It's a totally different world.
So the next time you see one of those advertisements, remember that beneath the slick branding, there's an entire world of tissue mechanisms, radiation physics, and vital medical vetting that needs to happen first. You cannot just iron the bed sheets and expect the structural damage underneath to fix itself.